Jennifer Clark for DMG TV2's Medical Minutes. This time around, we explore the nagging carpal tunnel syndrome with orthopedic surgeon Dr. Ira Richterman. And guys, we talk about screening for testicular cancer with urologist Dr. Mike Gigax. It's also Occupational Therapy Month, so we'll visit with Union Hospital occupational therapist Adrian Pedersen. So join us for this episode of DMG TV2's Medical Minutes.
For chronic sinusitis sufferers, the idea of going to the hospital for invasive surgery may deter them from getting help. But thanks to Dr. Kurt Guerin, ENT, those days are over. Dr. Guerin is the first ear, nose, and throat specialist in Northeast Ohio to regularly offer balloon sinuplasty right in the comfort of his own office in Dover.
A nursing home or your own home, it's good to be home. So call Ember Complete Care for all of your home health needs. When you're recovering from illness or injury, our compassionate staff promotes healing in the most comfortable environment of all, your own home. For skilled nursing, physical therapy, wound care, and more, Ember Complete Care serves all of Tuscarawas, Coshocton, and Harrison counties. Call 800-462-0909. Ember Complete Care. It's good to be home.
Welcome back to DMG TV2's Medical Minutes. I'm again Jennifer Clark, and with us on this segment is Dr. Ira Richterman. Welcome.
Thank you. Thanks for having me.
And you are an orthopedic specialist, and we're going to be talking about carpal tunnel syndrome. So tell us a little bit about your practice. What do you do?
Well, I'm a hand, upper extremity, and microvascular surgeon.
A what?
A hand, upper extremity, hands, and microvascular surgeon, which deals with the nerves and the arteries. My specialty is essentially elbows to fingertips. I'm with Omni Orthopedics, and where we have several office locations. We're down here in Dover. I've been practicing actually in Dover for nearly 7 years now, and our main office at Omni Orthopedics is up in Canton, and we also have another satellite office out in Carrollton. I do the hand surgery in our group along with one of my other partners, Dr. Klimo, and we all have different specialties in the group, and my love and my interest is hands.
And when you think of hands, at least when I do, I think of carpal tunnel syndrome because I have it. What is carpal tunnel syndrome?
Well, carpal tunnel syndrome is actually one of the most common things I see in the office. And by definition, it's a problem. It's called a compressive neuropathy. And a compressive neuropathy, there's something external pushing on the nerve.
So it's squeezing it.
It's squeezing it or putting pressure on it. I usually tell patients it's analogous to a hose. If you stepped on a hose and you decrease the amount of water coming out the end of the hose, that would be carpal tunnel syndrome for the hose. In the hand, when you have pressure on the nerve at the wrist, what happens is that you'll get numbness and tingling in your fingers, especially at nighttime. Patients will wake up every 2 or 3 hours. They'll shake out their hands. It's no different than if your leg fell asleep in the movie theater and you first get up and you try to walk and you got those pins and needles kind of feeling in your feet. That's the same thing that you get in your hands. You'll wake up, you'll shake your hands out every 2 or 3 hours. You'll try to go back to sleep, it'll wake you up again. You'll have activity numbness, for example, when if you're riding your motorcycle, which is big in this part of the country, and you're riding down the road or you're driving the car, you have a tendency to keep playing the switch game with your hands to shake them out. With women, if they're blow drying their hair, if they have long hair, by the time they're done blow drying their hair, their hands are numb, and then they have the difficult time with the mascara because they can't feel their fingertips, and that's classically carpal tunnel.
And I hear a lot about repetitive motions. You know, I do a lot of typing. Is that why I don't have a lot of feeling in my hands at the middle of the night?
Well, there's different reasons that people will discuss that increase the incidence of you developing carpal tunnel syndrome. First and foremost, there's some genetic components. For example, there's a much greater incidence in women than in men. Women say they'll work harder, men say they're built better. So whatever arguments you want to use there, the majority of individuals are above ideal body weight. I think unfortunately that's an American problem, not necessarily a thing with regards to carpal tunnel. But there's other factors medically first that I think people need to be aware of that increase the incidence of carpal tunnel or numbness and tingling in their fingers per se. Diabetes being the most common, there's something called a diabetic neuropathy, which is a problem with the nerves themselves, which more commonly will lead to problems in the feet. And I know in our other medical minutes that we've had various foot ailments that were discussed, and diabetes also can lead to the same problems in the hand. Other hormone problems such as thyroid disease will also cause numbness and tingling in the fingers. With the treatment of certain cancers such as breast cancers, there's some chemotherapy agents that have, unfortunately, as a side effect, they have some damaging effect to nerves, and they can give you some numbness and tingling in the fingers. So first and foremost, there's other factors and other disease processes that also will mimic the same symptoms with regards to carpal tunnel. Another very common one is people that have a herniated disc in their neck, or degenerative changes or arthritic changes in their neck that pushes on the same nerve but at the other end. So the end result is still numbness in the fingers, but the cause may not be down from the hand level. The cause may be coming from the neck level. Things that you do in your environment. You mentioned repetitive activities. Certainly repetitive activities play one component into aggravating the situation, because as you do a lot of work, let's say you're doing the big weekend warrior and you're raking up all the leaves in your yard one fall, and you're holding on to that equipment for long periods of time, that will definitely increase the incidence or increase or aggravate your symptoms. But probably the largest component that causes problems with your nerves is vibration. So for people that have play in their wood workshop, for example, and they're working with a random orbital sander, individuals that work with engravers, or any kind of tools that have a large vibratory component to it, when you hold on to that equipment for long periods of time, vibration is definitely shown to be very damaging to nerves.
Now you mentioned a variety of things that might damage that nerve or pinch that nerve somehow. How do you test for that? How do you know for sure that it's carpal tunnel syndrome?
It's a great question. When people come into the office and their history is suspicious of carpal tunnel, there's some things that we do in the office first from a physical exam perspective to kind of help us make the diagnosis of carpal tunnel. One would be, for example, just as simply as just when I touch their middle finger compared to their pinky. Their middle finger is controlled by the nerve that goes through the carpal tunnel. Their pinky does not. So a lot of times people with carpal tunnel, their middle finger will feel slightly different or slightly numb compared to their pinky. When your hands wake you up at nighttime, for example, your pinky should stay good compared to all the other fingers because your pinky won't be involved. There's another test, simple test called a Tinel's test. When the nerve is irritated, if you tap on the irritated nerve, it'll send kind of shocks or tingles to your fingertips. There's another test called a Phelan's test, whereby you bend your wrist down like this in this position, and you hold it for up to about a minute, and that will also recreate numbness and tingling in your fingertips. And those are by far the most simplest things to do. If somebody has very severe carpal tunnel, for example, we all normally have a nice big muscle in our thumb, but if you have very severe carpal tunnel, especially in the elderly population, this muscle may be wasted away and you have a kind of a sunken in spot. So if I'm out and I see somebody's hands, or if I'm in the office and I see kind of I use the expression a bird bath kind of effect, then I know they have very severe carpal tunnel. So before we run to testing, history and physical exam is perhaps the most important aspect. If I'm suspicious of carpal tunnel based on the history and physical exam, then we do a nerve test on individuals to basically confirm our diagnosis, to assess its severity, and to make sure there's not other medical problems that are also contributing to the numbness in the hand.
So once you've decided, yes, it's definitely carpal tunnel, what do you do about it?
Well, if we have a test that it comes back on individuals, and oftentimes they're going to have 4 results to their test. Well, I should say they should have 5 results. One would be if they're normal with regards to the carpal tunnel and the problem is elsewhere. Let's say they have normal for carpal tunnel, but the problem is at the level of their neck. I would refer them to one of the other doctors in our group who takes care of that situation. But the test, if it comes back positive for carpal tunnel, they'll come back as either mild, moderate, severe, or chronic. And it's really based off of the results of the nerve test and the patient's symptoms determines what our treatment path is. If the individuals have mild symptoms and test mild on their nerve test, we want to do simple things with those individuals to help alleviate their symptoms. One of which is to wear splints on the wrist when they sleep at night. The natural thing to do when you sleep at night is we kind of all curl up, whether we hug our pillow, hug our spouse, whatever it may be, we have a tendency to curl up. just like the little Phalen's test that we did on people. That's one of the reasons why people will wake up at nighttime with the buzzing in their fingertips. In those individuals, we have them wear splints when they sleep at night just to help hold their wrist in a straight position. During the day, activity modification. Obviously, if you are out there, again, doing the big weekend warrior projects and your hands are really tingling a lot, if you back off your activities a little bit. A big hot topic is ergonometrics. It is a way to place or position your body in your workplace to make it more comfortable. For example, with regards to typing or computers, sometimes people will change the height of their keyboard to make it more comfortable.
Or keyboards that are
Or
separated.
Yep, exactly. They'll do a split keyboard. They'll do different kinds of mouse configurations, from a traditional mouse to the ones where the ball floats on the top.
When do you decide to do surgery? Because I've heard that too.
Yeah, absolutely. It really is dependent upon the severity of their symptoms and their nerve test. If their symptoms get to the point where they're waking them up at nighttime, every 2 or 3 hours people can't sleep, they're shaking out their hands, and they have moderate or worse changes on their nerve test at that point, that's when I usually recommend surgical intervention. The reason being is once you get moderate changes on your nerve test with nighttime symptoms, it is a known fact that the longer you let that go without taking the pressure off the nerve, the more irreversible the changes become and the more permanent they become. Once changes become permanent, the fingers may stay permanently numb even though we take the pressure off the nerve. So the best rule of thumb I try to tell people is the minute that you have nighttime symptoms with them pins and needles, you really need to be evaluated and have a nerve test. If you have moderate or worse changes, at that point in time, I really recommend that you have a carpal tunnel release in order to take the pressure off the nerve to try to forego permanent changes.
Well, thank you for that great information on carpal tunnel syndrome. Dr. Ira Richterman here on DMG TV2's Medical Minutes.
A nursing home or your own home, it's good to be home. So call Ember Complete Care for all of your home health needs. When you're recovering from illness or injury, our compassionate staff promotes healing in the most comfortable environment of all, your own home. For skilled nursing, physical therapy, wound care, and more, Ember Complete Care serves all of Tuscarawas, Coshocton, and Harrison counties. Call 800-462-0909. Ember Complete Care. It's good to be home.
For chronic sinusitis sufferers, the idea of going to the hospital for invasive surgery may deter them from getting help. But thanks to Dr. Kurt Guerin, ENT, those days are over. Dr. Guerin is the first ear, nose, and throat specialist in Northeast Ohio to regularly offer balloon sinuplasty right in the comfort of his own office in Dover.
Welcome back to DMG TV2's Medical Minutes. I'm again Jennifer Clark. This segment, though, we have Dr. Mike Gigax. He is a Dover urologist, and we're going to talk about a very uncomfortable topic for men, testicular cancer. And it was really brought to the forefront because of athlete Lance Armstrong, who survived it, as many patients do, right?
That's true. It is probably the most curable solid organ cancer that we know of.
And what is it? It's just like breast cancer, ovarian cancer, cervical cancer, any kind of cancer you get.
Right, it just occurs in the testicles.
And how many people get it? Is it that frequent?
It's not all that common. The last incidence that I saw was about 1 in 250.
Well, that's pretty close then. I mean, there are plenty of people in Tuscarawas County or throughout our area who could have testicular cancer.
Sure.
And how do you know? What are the symptoms?
Well, typically men will notice a lump in the testicle. Usually it's not painful, so oftentimes in the shower they'll notice it.
Sounds like breast cancer.
Right.
Same thing. And how do you screen for it?
Well, the American Urological Association and the American Cancer Society recommend monthly testicular self-examination. It is typically a disease of young men, ages 15 to 35, and so those are the age ranges that are really recommended for the monthly
Why
screening.
young men?
After you go through puberty, the hormonal changes tend to cause that to occur.
And what do? Can you treat it? obviously. You
It's
said
very
it's
treatable, right. And so if you notice a lump, the first thing to do is to go to your doctor and have an examination. There are a lot of things that can feel like a lump in the testicle that are not in fact malignant, but that certainly is best sorted out by the physician. Oftentimes the patient will need an ultrasound of the scrotum to make the diagnosis.
And then what do you do to treat it? Chemotherapy, radiation?
Well, typically the first step is actually removal of the testicle, what we call a radical orchiectomy. And that's where the testicle is removed through an incision in the groin, very much so like a hernia. And that removes the testicle as well as the spermatic cord that supplies the blood flow to the testicle.
And that's all you have to do?
Well, typically, sometimes. So the way it usually works is we remove the testicle and then it goes down to the pathologist and they tell us exactly what type of cancer it is, if in fact it is cancer. And then there are numerous types of testicular cancer, and based on the type, then if everything is, you usually get a CAT scan. If everything's clear, then sometimes you get no additional treatment but very close follow-up. Sometimes we give radiation therapy prophylactically, actually, to try to prevent recurrence, although that's becoming a little bit less popular these days.
Does it recur often?
It does have a high risk of recurrence.
Even after surgery?
After removal of the testicle, yeah. And now, after the testicle is removed and the diagnosis of cancer is confirmed, the patient will have a CAT scan of the abdomen and pelvis, and usually of the chest as well. And if there is signs that it has spread into the abdomen, then oftentimes those patients will go through chemotherapy.
And once cancer's spreading, that's a bad sign, right?
It is a bad sign, but again, testicular cancer is highly curable and it's very responsive to chemotherapy.
And any way to prevent it?
No, we don't know of any ways to prevent it. Early diagnosis is the key, and in many patients, just removal of the testicle is curative if it's caught in time. So screening is probably the most important thing.
And I can't imagine what your patients say to you. Are you kidding? They probably are really caught off guard.
Well, a lot of men are very concerned when they have when they notice a lump, and so I don't know that they're...
How do they come forward? I mean, this is a very personal area we're talking about. They don't just pick up the phone and say, hey, I need an exam. I'm sure it takes a lot of courage.
Yeah, well, a lot of guys are so worried about it, though, they are more than willing to come in and have it checked.
And you hear a lot about other cancers, as we were just talking about. They get so much awareness and publicity. Do you think testicular cancer should have that much awareness campaigns for it too?
Well, I think that it's important that young men do check their testicles. I mean, it's such a simple thing to do, in the shower once a month. Just make sure you don't feel any hard lumps, or anything that's concerning at all. So it probably should have a little bit more publicity, I guess.
Well, it is National Testicular Cancer Awareness Month, so if there's an entire awareness month dedicated to this particular cancer, I would think that it was something that you need to really pay attention to. Mm-hmm. All right. And like we said, if you think there's any problem, no matter what kind of cancer, you should always just call your doctor.
Right.
Well, very good. Dr. Mike Gigax, a urologist here in Dover on DMG TV2's Medical Minutes. More to come.
For chronic sinusitis sufferers, the idea of going to the hospital for invasive surgery may deter them from getting help. But thanks to Dr. Kurt Guerin, ENT, those days are over. Dr. Guerin is the first ear, nose, and throat specialist in Northeast Ohio to regularly offer balloon sinuplasty right in the comfort of his own office in Dover.
Looking for ways to get a return on your marketing investment? Get results with Digital Marketing Group. We provide a digital marketing solution with state-of-the-art opportunities to increase your visibility in the community, optimize your digital presence, and maximize your marketing investment. We specialize in affordable websites, custom mobile apps, search engine and social media optimization, high-definition video production, broadcast television. If it's digital, we develop it. If you're looking for a way to increase your profitability, obtain new customers, retain current customers, and get the return on your marketing investment, then go digital. Get results with Digital Marketing Group. A nursing home or your own home, it's good to be home. So call Ember Complete Care for all of your home health needs. When you're recovering from illness or injury, our compassionate staff promotes healing in the most comfortable environment of all, your own home. For skilled nursing, physical therapy, wound care, and more, Ember Complete Care serves all of Tuscarawas, Coshocton, and Harrison counties. Call 800-462-0909. Ember Complete Care. It's good to be home.
Hello, welcome back to DMG TV2's Medical Minutes. I'm Jennifer Clark, and on this segment, we have Adrienne Pedersen. She is an occupational therapist with the Union Hospital Inpatient Treatment Facility. What do you guys do at the Inpatient Rehab Center?
Well, actually, it's a 10-bed unit. We see patients of various diagnoses, so we're seeing a lot of strokes. We see some orthopedic patients, hip fractures. We see other various neurologic diagnoses like Parkinson's disease, those kind of things, and then just the general debility, you know. And
it's an inpatient, so you stay the night. You don't just come and go.
Correct. Yes, you're admitted, and depending on what your deficits are, they base your length of stay. So that's kind of judged upon where you're at when you come in. So.
And when we talk therapy, you're an occupational therapist. What's the difference between physical therapy and occupational therapy?
That's a good,
One
very
sounds
good.
longer than the other.
Well, occupational therapy a lot of times goes unknown. A lot of people think that when we say, I'm an occupational therapist, they say, I don't need occupational therapy, I'm retired.
Job
so they
training?
think, yeah, that it's related to the jobs. But actually, the biggest difference is that we are trying to rehabilitate their activities of daily living. So it's based on their occupation of life, whether that be cooking, cleaning, maybe it is their work or a leisure activity that they do, maybe it's somebody that likes to golf, but they have paralysis on one side of their body. We're trying to find ways, adaptive strategies to allow them to resume those activities that are meaningful to
whatever
them.
you do in daily life.
Yes.
Picking up a fork might be difficult for a Parkinson's patient.
Correct, yes.
And how many patients do you see? I mean, you said you had 10 beds?
It's 10 beds. Actually, on the rehab unit, we do 3 hours of therapy a day. So that is split between the 2 disciplines, sometimes 3, so speech therapy can be involved. So we usually carry a caseload of about 5 patients each because
And you
of
see
the
all
intense
5 every
therapy.
day?
Yes, we see them every day for about 90 minutes apiece. So.
And is it hard work for them?
It is. It's a very intense program, but I tell you, it's so rewarding. You see big gains in their progress, so it's a really rewarding thing to.
And I guess it would depend, how long they would need occupational therapy. Depends on what they're dealing with.
Correct. It'd be based on their diagnosis, their deficits, how they come in.
Do some only come for a few days, other come for months?
We've had some that come, for as long as maybe a week, 5 days. We've had others that stay maybe up to a month, usually not that long. We're very intense program, so we see them, we like to, come hard. They work 3 hours a day, and then we like to get them home, so.
And when they're at home, they should continue their therapy on their own.
Correct, yes. A lot of the patients either get home health or they go for outpatient once they leave our facility.
And where do you get your patients? Are they referred to you? Do they have to be Union Hospital patients?
They don't have to be Union Hospital. So we get some in-house patients that come, as referrals, and we also get some outside source referrals as well. So they could come from anywhere.
Do you have to do it? I mean, if your doctor says, oh, you need occupational therapy, what if you don't want to? Do you have patients that say, I don't want to be here?
Yeah, there are people that say they don't want to be there. Obviously they have that opportunity to refuse, but very few would ever say that. So,
Especially after they go through some sessions and see how they improve.
right. Yeah, I think initially it's kind of, hard for them, but then once they get involved in the program, they really see the rewards of it. So.
And you said some people don't understand what occupational therapy is. Do you find that on the professional level too, that they're not quite sure if they need physical therapy for something specific like a knee injury versus the occupational therapy? Is that on the professional level too?
We see that very often, and I can tell you just from being in college that was one thing we were educated a lot on, that we needed to, go out and educate people, because a lot of people aren't aware of what occupational therapy is. So even sometimes physicians may come into the unit and they're not really aware of it, and they just think that everything is physical therapy. So it's nice sometimes to be able to talk about, what it really is.
And what's some of the equipment that you use? Do you have tennis balls, or do you really have like a kitchen where they could pretend that they're at home?
We do have a kitchen. We have people make meals, prep, whether they're using a walker, they're doing it from a wheelchair level.
With sharp knives?
Assisted. We use knives. We have everything. We have built-up silverware, which is nice for people that may have arthritis or, like you said, Parkinson's.
So it's a thicker handle, so that's easier to grab.
Yes. So we've got it all. We have washer dryer. We have people do laundry.
Golf clubs?
We don't, but we have a Wii, so we do have people do that. But whatever that they do at home, we like to adapt it or provide strategies for them to do. Given their deficits.
And is there any specific medical equipment involved?
Like I said, the walker, if people are using that. Also, when it comes to self-care tasks, we use a lot of, whether they need an extended tub bench to be able to get back in their bathtub to bathe, or we also use adaptive equipment, including there's things that are reachers, sock aids that would help you put your socks on, if you have a problem to where you can't bend over. So there's a lot of different gadgets that we like to kind of incorporate.
There's probably something new coming out all the time.
Oh, yes.
How do you keep up to date?
We usually have, every year they give us new catalogs, so we can kind of sift through that to see what else is new out there. But yeah, lots of stuff.
Well, it sounds like a really fun job, that it would be really rewarding when somebody, that light bulb goes on, they can do something that they couldn't do before. What do you like best about your job?
What I like best about my job and the setting that I work in is that we see them at their worst when they come in. They may have been in the hospital for weeks and weeks. Sometimes we see people that have been in the hospital for a month. So we're seeing them at their worst, but it's so rewarding then to see that day that they get to go home. So you see them at their best, and we really get to, go through that journey with them and get them back to being able to be at that independent level, whether it be using an assistive device or not. So.
Do they ever have to come back?
Some people do, but usually it's if if they've had something else traumatic or something happen. But in most cases, when they come back, they're coming back as a visit to say hello, to kind of let us see how good they're doing. So.
And say thanks.
Yes.
Wow. Well, this is Occupational Therapy Month, which is why we wanted to have Adrienne on to explain what occupational therapy is. And now we all know what it is, so we can give you a call here at Union Hospital and see how you're doing.
Yeah.
Occupational Therapy Month, and you have been watching DMG TV2's Medical Minutes. Our guest this segment, Adrienne Pedersen. She is an occupational therapist with Union Hospital in Dover, and I'm Jennifer Clark.